Hi, thanks for watching episode number 95 of the Doctor Podcast Cykiert File Show. And I'm your host, as usual, Dr. Robert Cykiert. Thanks very much for joining us today. And please subscribe, follow, like, repost, and share this episode so we can get more great guests like we have today, Dr. Jessica Oswald. And today we're discussing an extremely important topic. It's a medical condition that everyone on the planet has experienced at some point. And that condition is called pain. Everybody has had pain at some point or another. And as you know, there are different medications that are used for treating pain, and some of them have been problematic, such as the opioids. And today we have an expert to discuss pain and the treatment of pain. And very importantly, we're going to discuss a new drug that was approved about a month ago by the FDA for treating moderate and severe pain. It's called Journavx. And Journavx is not an opioid, and it's a breakthrough medication. It's the first medication approved for treating pain in about 20 years. So our guest today is an expert in this. It's Dr. Jessica Oswald. She's an associate professor in the Department of Emergency Medicine and the Department of Anesthesiology and Division of Pain Medicine at the prestigious University of California in San Diego. She's an anesthesiologist and is board certified in pain management and also in emergency medicine. She's also an expert in opioid disorders. She's also an expert witness consultant in medical legal matters. She's a master of public health in biostatistics and epidemiology as well. She's also the chair of the FDA Consensus Guideline Development Group for low back pain. And she's a former professional surfer, which we'll get into a little bit later. So, Jessica, thanks very much for taking the time to join us today to discuss this important topic of pain. We really appreciate it.
Absolutely. My pleasure to be here.
Thank you. So I want to start by discussing the different classifications of oral pain medications that are used for mild and moderate pain. Can you tell us about that?
Yeah, and I think that provides a good foundation to our discussion. Um, when someone has pain, typically what I do is I treat it with a multimodal approach. And that's going to include my non-opioid analgesics. And that's going to be my acetaminophen and my non-steroidal anti-inflammatory drugs like ibuprofen, naproxen, Celebrex, diclofenac, etc. Then I will layer in, if the patient's pain is not controlled with the non-opioid analgesics, I'll layer in my adjunct analgesics, and that's going to be my anticonvulsants. People are more familiar with the name gabapentin and Lyrica. And if that's ineffective, I start looking at my antidepressants, tricyclic antidepressants, and my serotonin norepinephrine reuptake inhibitors, or the SNRIs, like duloxetine and venlafaxine. We have our muscle relaxers and our topical analgesics. And if
Yeah,
all of those are ineffective, we start looking at or considering opioids.
I see. So opioids are sort of the last step that you would use. What about the common over-the-counter products like Tylenol, aspirin, ibuprofen, naproxen, or Aleve? Are those roughly equivalent, or some are more effective than others?
And they work differently. And so I typically like to say if a patient doesn't have any other contraindications, I like to use them together. So your acetaminophen or Tylenol is going to work, and this is going to work by reducing pain centrally. You always got to worry about hepatotoxicity, particularly with really high doses greater than 3 or 4 grams. Then you have your aspirin, which is considered an NSAID, and this irreversibly inhibits your COX-1 and COX-2. This is going to reduce inflammation, pain, and fever. Typically will last for 4 to 6 hours, but has the problem of GI upset, irritation, and sometimes at high doses, people can complain of their ears ringing. And then we have our NSAIDs, and these are going to reversibly inhibit your COX-1 and COX-2 inhibitors. And that's going to be your ibuprofen that lasts for about 4 to 6 hours. And then we have naproxen. And naproxen is just like ibuprofen. It reversibly inhibits the COX-1 and COX-2 inhibitors, but lasts longer, 8 to 12 hours.
And you can combine some of these medications together if patients have more moderate pain, right?
Absolutely. So I'm frequently combining these medications. The term I like to use is what I like to tell patients, I'm attacking it from every angle. So I'm going to use an NSAID, I'm going to use acetaminophen, I'm going to try to use some sort of antidepressant. My go-to is duloxetine. And duloxetine, interestingly enough, is thought to have some sort of NAV activity. And the topic of this discussion is Journavx, and Journavx works on the NAV receptors. And so duloxetine has some NAV activity and might be the reason why it's so effective with pain. And then I'll use a muscle relaxer if the pain condition has some spasticity associated that's painful. And a topical. I always ask patients to try topical lidocaine to the area of pain.
What about topical NSAIDs? I think they sell those over the counter as well. Do they work for pain as well?
Absolutely. I find that it works better over pain that's a little more superficial. So, maybe a knee or a shoulder. I find that patients that have back pain that's really from a deep source, maybe nerve compression, is going to be less effective.
You find that the topical lidocaine patches work better than the topical NSAIDs, or are they equivalent or different in different patients?
Different in different patients.
Mm. All right, so you try them out and see which works. Now, let's get into more moderate and severe pain. You mentioned that when you've exhausted all these other medications that you've tried, you go to opioids. And what are the common opioids that are prescribed for treating pain, and what sorts of conditions are they prescribed for?
Yeah, and I like to say I really try everything to not use an opioid. So when you see me in my pain clinic, I will be optimizing the medications using everything we described above. And then I'm typically trying to understand what's driving this pain. Is there something I can target? So by and large, a lot of what I see is back pain. Is it from the joints in the low back? Is it from a compressed nerve? And can I offer a procedure that would target that? And so that would be an epidural or maybe some sort of radiofrequency ablation or sacral iliac joint injection. And most of my patients, I'm able to get better for at least a couple months. I don't need to prescribe an opioid, but I do have a subset of patients that just don't get better and that are miserable and have a poor quality of life. And it's at that point we have discussion of opioids. And I really like to reserve opioid initiation in particular my older patients that just aren't thriving um, towards kind of the end of their lives. And I feel that they are struggling just with activity of daily living. And that's when I start thinking about adding an opioid.
So we've heard about in the last 5 or 10 years the opioid addiction epidemic. There's been a lot of overdoses. Why are opioids addicting? Can you explain that in terms that the audience will understand?
Yes. So the opioids um, act on the mu receptor, and through a series of mechanisms, it floods the brain with dopamine. And there's been a lot of interest in the dopamine hits, dopamine response, and it's addictive. There's a lot of things that can release dopamine in the brain. And one thing we always say is like tablets and iPhones and social media releases dopamine. We really like that dopamine hit. We go back for more. And the same thing, opioids. Opioids are flooding the brain with dopamine. And so you take it once, and then you may get this flood of dopamine, and then all of a sudden you feel that you need to continue to take it to get those dopamine hits.
I see. So the brain gets accustomed to it and wants more and more in the reward center.
Exactly.
Now, are different people more prone to getting addicted to opioids than others?
Yes. And so every patient that we see in our pain clinic, we screen whether or not they're on opioids. We screen them with something called our opioid risk tool, and that's asking patients, do they have a family history of addiction to opioids, addiction to alcohol? Do they have any pre-existing psychiatric conditions, depression, OCD, bipolar disorder, and have they ever had been sexually abused, and how old they are, and also their gender. And all of these kind of factors can not perfectly, but help us predict who's at higher risk for developing some sort of opioid use disorder.
I see. So you can figure that out to some degree before you prescribe it in those patients where you need to use it.
Yep.
Now, I've heard, I don't know if this is true, tell us if it's true or not, that if you're taking opioids for severe pain and then the pain stops, it's easier to get off the opioids because the pain is gone and now you don't need them anymore. Is that true? Or even if the pain goes away now, you're still stuck with this dopamine craving and you get addicted?
Well, we have to really tease out the difference between addiction and dependence. So if someone is chronically on opioids for, let's say, hip pain, okay, and they get a hip replacement and their hip pain goes away, what happens if they discontinue their opioid? And frequently, what can happen is the patient starts feeling withdrawal symptoms that they perceive as continued hip pain. And the example I like to give my patients is, well, we have heroin addicts that use heroin. When they come off there and they have no pain at all. And now it's fentanyl. And when they get off their fentanyl, they have the most horrific total body pain they've ever experienced. And it's not because they have a condition that's causing the pain, it's their body is seeking that opioid. And similarly, if someone's on a long-standing opioids, maybe kind of a moderate dose, let's say 45, 50 MMEs, and they suddenly discontinue their opioids because they had their hip replacement and they feel that the pain should be gone, they will feel horrible pain. And that horrible pain is that withdrawal symptom. Now, were they addicted to the opioid? I don't think so. I think their body just got used and became tolerable to the dose that they were on. And when they took it away, suddenly they felt the withdrawal symptoms. So what we typically do is slowly taper the opioid down when the pain is gone.
And that hopefully avoids that problem. Now, why were opioids overprescribed in the last decade? What caused that?
A lot of marketing from Purdue Pharma. You know, they developed OxyContin and they marketed to patients and to providers that we were under treating pain. And that really resonated. You're taking a group of physicians that really want to help people, and you're telling them the way you can help them is take away their pain. And patients' pain is almost with opioids never really goes down to a zero. It becomes more tolerable, but as you continue to take the opioid, you're going to need more and more and more to have that same effect. And Purdue Pharma kept telling all the physicians this is not addictive. The patients were saying it's not addictive, and it really got out of control.
Wow, tragic story. Now, currently, fentanyl seems to be the opioid that's most abused. What's the difference between the older morphine that was used and then heroin and now fentanyl? What's the difference between those three opioids?
So fentanyl is 50 to 100 times stronger than morphine and 50 times stronger than heroin. It's cheap, it's relatively clean, it's small, so it's easy to smuggle in. And people really don't even realize how strong it is and it leads, that's what's leading to all of our accidental overdoses.
What it does is suppresses the breathing. So you basically stop breathing and then you die, right?
Exactly. So it crosses the blood-brain barrier, it works on the new receptors, and you get all the central effects of opioids. So you get respiratory depression, is the biggest one. And you stop breathing, essentially. Yeah.
Terrible. Now, fentanyl is used by anesthesiologists in the hospital during surgery. I know I do cataract surgery, and occasionally patients get a small dose of fentanyl. What's the difference between that and the fentanyl that's abused on the street?
And how it's made. The fentanyl that's abused in the street is made in garages and sheds in there's no I can't tell you how much you're getting. So in the hospital, we frequently know exactly what dose we're giving. So if we're going to give 50 micrograms of fentanyl, it's 50 micrograms of fentanyl. You don't know what you're getting in the street. So if a and I find that some of the users are rather sophisticated. So let's say they think they're giving themselves, and they actually would dose, they give themselves 50 micrograms. They think they're giving themselves 50 micrograms or a gram. When they get very dependent, they'll say, I use 2 grams of fentanyl every 3 or 4 hours. And so if they buy 2 grams of fentanyl, okay, one day, and they buy 2 grams of fentanyl another day, that 2 grams may be actually 6 or 7 grams. They just don't know, and that causes the overdose.
So in the hospital, it's well controlled. You know exactly what the dosage is. The dosage is small, and the anesthesiologist is monitoring your breathing and your heart,
Absolutely. Yes.
making sure everything's okay.
Yeah.
All right, that's important to know. Now, I want to go to the next topic, which is extremely important, and that is this new drug that was approved about a month ago. It's called Journavx, or suzetrigine is the generic name. Can you tell us about that new drug and tell us how you were involved in that development?
Yeah. So Journavx is a peripherally acting non-opioid alternative. It works on the NaV 1.8 receptor, which is a receptor thought to be extremely important in the propagation of pain, the receptor that sends pain signals to the brain. So by blocking this pain signal, you are no longer sending signals to the brain that you're in pain. My role was I sit on the steering committee for suzetrigine or for Vertex. And
Vertex is the company that makes the Journavx.
yes, so I am on the steering committee for Vertex Pharmaceuticals, and um, I help provide input to the design of their clinical trials, of predominantly, basically their phase 3 clinical trials.
And you mentioned that this blocks the peripheral nerve pain transmission. Is that right? So it doesn't get into the brain.
Correct. So suzetrigine does cross the blood-brain barrier, but it only binds the NaV 1.8 receptor, which is not in the brain.
I see. Okay. And it does not in any way bind to opioid receptors and doesn't cause release of dopamine in the brain.
Correct. So it does not have, as far as what the studies have published and what we know, it has no central effects. It does not bind to any receptors in the brain.
So therefore, it's not addicting.
Yes.
That's great. Now, what is it approved for? Is it for mild pain, moderate pain, severe pain, all of the above?
It's moderate to severe pain that's acute in nature, and acute is defined as less than 3 months.
I see. So it would be good for post-operative pain as well. If somebody's had surgery, let's say knee replacement, and they need pain medications for a while, that would be useful.
Absolutely. And knee replacement surgeries are well known to be painful, and patients require opioids, and they require opioids for quite some time. And while not specifically studied in postoperative knee replacements, that would be a great a great population to use suzetrigine on.
Right. And is that drug, the Journavx, given orally or is it intravenously? How's it given?
Nope, it's orally and it's taken twice a day.
Okay. And how long can you use it for? If you've had some joint replacement surgery, you can have pain for weeks, sometimes longer. How long can you use Journavx for?
I believe the FDA label does not actually provide a
Hmm,
timeline as for how long you can take it. Now, it's recommended to be taken for up to 14 days or until your pain stops.
I
But
see.
my understanding, there's actually no endpoint. So if you wanted to take it longer, you could. But the recommendation is you prescribe it 14 days. And if your pain has resolved after 5 or 6, you can discontinue it at that time.
So, how long does it take for the Journavx to work? Let's say you're having postoperative pain after joint replacement surgery and you take the pill. How long does it take for it to relieve the pain?
The studies have shown it takes about 2 to 4 hours.
2 to 4. And it lasts for roughly 12 hours because you said you take it twice a day.
Exactly.
And can it be used in combination with the other medications that you mentioned, such as Tylenol or ibuprofen or Aleve?
Absolutely. The studies have shown that it can be used either as a monotherapy or as part of a multimodal kind of regimen.
That's great. So you have a synergistic effect with other safe drugs as
Mhm.
opposed to using opioids. Now, what side effects or risks does it have? I know it's new and it was just approved, but in the clinical trial, were there any significant adverse effects or risks from it?
So the clinical trials showed that Journavx was extremely safe. And in fact, if you look at the common side effects, which was nausea, constipation, headache, those side effects were higher in the placebo group than actually the treatment
Really?
arm.
Wow.
But um, when reviewing the studies, the FDA didn't like the fact that Vertex was like, it's basically safe. It's safer than placebo. So you have to include some sort of side effect. So when you read the label will actually list some side effects that are very, very low. So, one of the side effects was muscle spasm or cramp, and I believe the placebo group was around 0.6% of the patients had muscle spasm or cramps, and then the treatment group had about 1%. Um, and then
Close.
they also list elevation in CPK. Now, the Vertex will say that it was clinically insignificant, it completely resolved, patients were asymptomatic, and it never reached the level was not all that elevated, but it's there. Um,
Right. So that
um,
needs to be monitored. That's an enzyme that indicates possible muscle damage.
right. And there's a lot of medications that affect that. And how this relates to, for instance, the statins, we just don't know.
Right. Now, is it covered by insurance, Journavx, or how expensive is it? Well,
We don't know. We don't know how insurance companies are going to cover it. It's about $30 a day.
$30 a day. All right. Now, in the clinical trials that were done to get Journavx approved, what kind of pain was treated, and what drugs was it compared to in treating the moderate or severe acute pain?
Yeah, so in order to get a medication FDA approved, the FDA requires these soft tissue and hard tissue models of pain. Okay. So to satisfy the kind of hard tissue, it's gonna be bony pain. Vertex ran a clinical trial of bunionectomies. And to satisfy the soft tissue model of pain, they used suzetrigine for abdominoplasties. And both of those clinical trials show that suzetrigine was superior to placebo in reducing moderate to severe pain. It was compared to Norco, and the study did not show that suzetrigine was superior to Norco in reducing pain. When you look at the curves, you can see that the pain reduction was very similar to Norco, but it was not superior.
See, but in combination with maybe Tylenol or an NSAID, it could in fact be as good as or possibly superior and not have the addiction problem.
It's hard to say. The study did not look at that,
I
and
see.
one would hope, um, and that needs to be further studied.
Right. We find out more about these drugs after they're started in clinical use after they're approved. So we'll find out more, but we're off to a great start. Now, can patients get started on that drug in the hospital right after surgery and then continue it when they're home and discharged from the hospital for the 14-day period or as long as they have a significant pain?
Yep, exactly. And in fact, there's discussion when a patient comes in to the OR and they're going to get a surgery. A lot of times we'll give them, you know, Lyrica right before they get their surgery because Lyrica has been shown to decrease post-op pain scores. So could you actually give suzetrigine immediately prior to the surgery? So then by the time their post-op is the level of suzetrigine going to be high enough to the where the point where the patient will maybe need less opioid. That could be maybe a change in the algorithm and how it's used.
Right. We'll find out as we gain more experience with the drug. And if a patient, let's say, has severe pain and they require some opioids as well, I don't know if you've studied this or not, maybe adding Journavx allows you to reduce the dosage of opioids and for how long they're used so that they're less addicting.
Yeah, the way I always kind of treat it in my mind, okay, so someone has moderate or severe pain. I'm going to start with my ibuprofen, my Tylenol. If they're post-op, I can give this IV. It may work a little bit faster. And I'm quickly titrating to get that patient comfortable. So at that point, I'm probably going to be giving my Journavx, and then I'm going to give something IV, and I'm going to wait until that Journavx starts to take effect. And I will know after, does that patient need as frequent and high of doses of IV opioid to get their pain controlled, or can I start tapering off my IV analgesics or IV opioids now that the Journavx is working in the system and potentially not have to prescribe an opioid or prescribe less?
Now, it's only been approved a short while. Do we know if there are any interactions with other drugs that patients may be on, especially in the elderly population? They're often on multiple medications. Are there any contraindications for usage with other medications?
Yep. So the label, it does work on the CYP enzymes. And so the label does state that there should be caution used when patients are on medications that interact with the CYP enzymes. Um, and the first dose should be taken on an empty stomach. And then after that, it doesn't necessarily matter. And so there are some interactions that should be noted.
Oh, sounds very promising. I think surgeons who do abdominal surgery and orthopedic surgery should try to use this and see if it can be used to avoid opioids completely. So that's great news.
Yeah,
Now,
I'm excited to really see how this plays out in the
mhm.
real world and all the different clinical applications potentially for this drug. And can it really decrease our need for opioids? I mean, that's extremely exciting. Just having something that I can offer um, that's a before I go to opioids, just one additional tool that I have.
That'll be great. That's awesome. One fascinating thing that I noticed on your website when I was reviewing it is that you were a professional surfer. Can you tell us about that and why you switched from surfing to being a doctor?
Oh, well, that was quite a long time ago. I grew up in Hawaii. Hawaii,
Hawaii, no wonder.
Oahu. So surfing is kind of the culture, and I love it. And I was always a good surfer, but I wasn't like the best surfer. I knew that. I knew I was good enough to get sponsors and be paid to surf, but I knew it wasn't going
Wow.
to be my end game. And when I would travel all over the world doing these competitions, I was always secretly very nerdy. In fact, a lot of my competitors didn't realize I was actually a full-time college student. While everyone else was in enjoying the location they were at and doing all of these things, I was trying to wake up early to study, to you know make sure I wasn't getting too far behind with my college classes, back in my institution. And um, so when I come back, I can actually take my exams. So there was always just something that didn't quite fit with the professional kind of surfing industry. As I was a little too studious back then. It's changed since. And the other thing, I think there's two things that happened. 9/11 happened and I lost all my sponsors. So I was kind of forced to seek an alternative career. And secondly, I competed against Chris Amore, who's now been a world champion multiple times, and she was young at that point. I mean, maybe she was 8 or 12, and I saw that she was a really good surfer. I knew she was going to be a world champion, and I knew I was never going to be as good as her. And so it was a combination of everything. I realized I should probably do something else with my life. It was fun, but I think I'm a little too academic. I can always surf, and I have to maybe go to medical school.
Great story. That's fascinating. Are you still surfing now when you get a chance?
Yep. I try to surf a couple of times a month. Not I used to surf every single day, and I have two children, and I just started meeting up with this moms group so I can bring my children and we rotate watching each other's children and we all get to go and surf, and it's a great community.
Wow. Are your kids surfing it?
No, I'll be happy if they can safely swim.
Right. That's a
Put them
good
in
start.
life jackets at the beach just because I'm so nervous about them jumping in the water. They love the water. They think they can swim, but not safely.
Right. That takes time. That's great. I want to thank you very much for taking time from your busy day of being a doctor and a surfer part-time to tell us about Journavx and the management of pain. This has been very informative for me, and I'm sure the audience as well. So thank you.
My pleasure. Thank you for having me.